Hello, everybody. So it's my pleasure to introduce this session of the working group on clinical and translational issues. We are going to have two presentations today. The first one from Barbara Abbas, who is chair of the Department of Surgery at the Methodist Hospital. She's going to talk about breast conservative therapy, essentially the clinical aspect, and it will give the basis for the modeling aspect that we can discuss. And it's an interesting talk because we are trying to do modeling without any animal models. So it's really a clinical problem. The second talk will be presented by Kim Min, who is a surgeon, and is going to talk about metastatic cancer. So actually it's only ex vivo model for metastasis as far as I know. And the idea will be to, starting from the right biological model, what kind of computational model eventually the community can bring. And I felt that this is very important to have a presentation of this ex vivo model. Well, so Barbara, please.
Okay, great. Well, I'm going to give the clinical setting in which the collaborative work that Marc Garbey and I have done together for the last several years, actually, focused on my area of clinical expertise, which is breast cancer. For those who are unaware, breast cancer is the most common solid malignancy of women in the United States, with over 50,000 new cases per year. It's one of those diseases which we have learned over the last 30 years really is not something we can manage with surgery alone, but it's something that requires integrated care using all of our modalities appropriate for management of solid tumors, that being surgery, radiation oncology, and the medical adjunctive treatments from hormonal therapy to chemotherapy. A key element in all of our surgery these days, particularly in breast, is the use of imaging. And imaging gives us lots and lots of information about the extent of disease, the position of the disease, and also facilitates our surgical planning. For those who are not familiar, here's the anatomy of the human breast. As you see, it's covered in an envelope. I wonder if they've lost me. It's covered in an envelope of skin, obviously, and it's really that skin that dictates, for the most part, the shape and ptotic appearance of the breast. This connection, particularly here at the inframammary crease, is very important in creating this ptotic appearance of the breast, which is an essential element of cosmesis. We also, of course, aim for symmetry when we evaluate breasts in terms of cosmesis. As you see, the tissue of the breast is quite heterogeneous and complex. We have subcutaneous fat. We have glandular elements, which are quite fibrous and firm. We have stromal tissue, and it's all adjacent to the chest wall, which is comprised of muscle and the underlying rib cage. Most breast cancers form in what we call the terminal ductolobular unit. It's a microscopic area of the breast that's within the glandular elements. When breast cancer spreads, it spreads first by way of invasion of the, virtue of the invasion of the lymphatics, and harbors first in these axillary lymph nodes, the first filter to capture most commonly the tumors from a breast cancer, and hence the use of the T as in tumor, N as in nodal, versus and then M staging system. Let's see if we can make this go down. Oh, brother. There we go. As a surgeon, my goals are really pretty simple. My job is to remove the primary tumor. Here's the tumor in the breast. And then also to sample the axillary lymph nodes to see if the disease has spread. Quite simply, that's what the surgeon does. But we do that as part of an integrated surgical care team. There's two fundamental options in breast cancer care these days. One is lumpectomy, where we remove just the tumor and a normal rim of breast tissue around the breast, versus total mastectomy, of which there are a variety of types. But basically, this removes all of the breast tissue that we can achieve removal of, knowing that it's not like a penny you can lift right out. It's actually adherent to those other tissues in the breast wall. This is the result of what a total mastectomy looks like in a patient who's not had any form of reconstruction. As you see, it's a fairly deforming operation that leaves the patient with no breast, no nipple areolar complex. Fortunately, these days, about 60 to 70% of women having with breast surgery are amenable to what we call breast-conserving therapy, where through a small incision such as this, we can go in and remove the tumor with some adjacent normal breast tissue, and then subsequently treat this remaining breast with whole breast radiotherapy. As you see, the cosmetic result can be quite satisfactory, and in fact, it is quite satisfying to women in 70 to 80% of the cases. Essential to breast-conserving therapy is removing the full tumor. You have to have this normal margin, pathologic margin around the breast tumor with normal breast tissue around it. We can't see or feel these tumors when we're operating on them, believe it or not, and pathologically, therefore, we occasionally have to deal with positive margins like this, which means going back to the operating room to excise additional tissue if need be. Another essential component of breast-conserving therapy is the use of radiation therapy. This is like our cleanup batter that basically kills any residual cancer cells that could have been spilled or in the adjacent breast tissues, and very effectively decreases recurrence risks of breast cancer in a treated breast down to the 5% range, which is really a very satisfactory option. When we consider breast-conserving therapy as a tool for treating breast cancer, there's several things that we want to do, essentially. We want to make sure we remove the whole tumor. In other words, we do an oncologically satisfying operation. We want to stage the patient in terms of looking at the lymph nodes under the breast. And we have learned with 35 years now of clinical trial outcomes that oncologically, in other words, from the cancer perspective, removing the tumor and staging the axilla and treating the breast with radiation is equivalent to removing the whole breast. And therefore, given that there's less surgical morbidity and you actually preserve a breast, it's a nice option for many, many women and can be done very safely. Of course, the goal of this is to make sure you're preserving a breast that has at least a satisfying cosmetic result for the patients. Occasionally, however, we don't have that satisfying result. Sometimes, given the position of the tumor or the patient's breast structure, the size of the tumor relative to the breast, we end up with a really quite unsatisfying cosmetic result such as this. Therefore, with careful surgical planning, we try to minimize the risk of that kind of poor deformity. But we do all of our surgery based on really fairly disintegrated imaging modalities. This, for example, is a mammogram, a left and right breast in two different views. And within this will be an area of density that, as you see, the study is performed with the breast in compressive status. It's very hard to take that and reconstruct in your own mind a three-dimensional picture of where that particular tumor is. That's how we do it, though. Similarly, we often can image these tumors to get a better feel of the dimension. Here's an irregular density consistent with a carcinoma within the background breast parenchyma. But as you see, we have no landmarks to position this in the breast relative to where I'm going to go to remove that tumor. A very useful modality we use a lot in our breast imaging now is the breast MRI. It's a very sensitive and specific test for, very sensitive test for picking up small malignancies and for assessing the status of a tumor within a breast. But as you see, to do this study, a woman lies prone, and so now you're dealing with a breast which is hanging down, and we are in our minds correlating or co-registering these three different modalities: the squished mammogram, the lie on your back, movable ultrasound, and then this pendulous MRI. It's quite a mind game to actually position these things very appropriately. However, with all that, what we are interested in our studies that Marc Garbey and I have done together for the last several years is to try to determine, using preoperative imaging and virtual lumpectomy, are we able to predict the contour outcome of the breast? We know we can do this from the oncologic perspective, but we want to know, and this is really something that no one really has looked at, is how can we predict the impact of a lumpectomy, this particular, for example, virtual lumpectomy around that small biopsy site, on the eventual contour of the breast. Well, it turns out that actually with a variety of modeling and mathematical reconstructions, we've actually been able to come up with some pretty nice modeling. I'm going to turn it over to Marc, who's a professor of computational science at the University of Houston and the director of scientific research at our Methodist Institute for Technology and Innovation and Education here at Methodist to carry on.
Okay, so I'm going to discuss, following Barbara, how we go from observation to prediction. And I call it the uphill battle of computational surgery because really nothing is simple here. It's quite complicated, as you will see. So what is the purpose of multiscale modeling here? What are the questions we are working with? For example, we do hypothesis-driven research, so we would like to know how multiscale modeling can be used to either refine the hypothesis for experimental validation or define a related hypothesis that can be more readily tested. We need to know when a virtual experiment would be acceptable as a way to test a clinical hypothesis. We would like to optimize the experimental plan, the clinical trials. We would like to identify the common bottleneck in this multiscale approach for this specific problem. We would like to have an effective strategies to integrate these various models and make sure they are consistent. And eventually, we have this MSM demonstration in clinical conditions. So this is something that we have been discussing at length with Bill Litton, with the co-chair of this working group on clinical and translational issues. And I really benefit from his point of view. So how do we go from observation to prediction for breast conservative therapy? So Barbara explained better than I would have been able to do it, the background. And our hypothesis is really that the complex interplay between mechanical forces due to gravity, breast tissue constitutive low distribution, and internal stress generated by the healing process play a dominant role in the success or failure of this lumpectomy in preserving the breast shape. And actually, I'm going to show that with our first patients. So our aim is really to define the immediate impact of tissue removal on breast deformation as a function of the tumor location and size, but we have to go far beyond, because the cosmetic outcome is a long-term process where you have the temporal interplay between mechanical forces, radiotherapy, and the biological process involved in tissue formation and plasticity. So that's a critical part that is really multiscale, and that will need to be worked out properly in order to have predictive model. And you cannot do that on your own. It's really an interdisciplinary team that does that. Interdisciplinary team at the level of the faculty, indeed, but also at the level of the students. Students who work on that are computer scientists, bioengineers, and so on. So the thing that is very key is that if we want to do anything useful here, we have to keep track of how it's going to be used by the surgeon. And it's not realistic to ask too much in terms of getting the data. You may get the location and size of the tumor removal. You have indeed from MRI tissue composition and some idea of tissue stiffness. You may have some idea on the background in terms of biology, how the patient is going to react to inflammation and healing. But still you have a very limited knowledge that you can acquire in clinical conditions. We are not talking about an animal model where we are trying to do very accurate validation here. We want to have a practical tool. And at the end of the day, we need to have cosmetic indicators and some functional indicator that the doctor can discuss with his patients. And we have to hide all the complexity of what's inside the box in terms of modeling and simulation. So this is really the goal in going to clinical and translational. So we started with a protocol and the idea of enrolling 12 patients. But thanks to Barbara, we were really very careful, and we started just with one patient, because we have the idea that we should do an agile development of this clinical study. We are not going to get it right with the first patients. It's going to take several patients. And actually, if we look at this protocol that we had initially, where we start to have typically the consent of the patient, an MRI that before the surgery, some surface imaging of the breast before surgery, and then at various points later on after surgery, some ultrasound imaging to monitor the lumpectomy healing, some surface imaging to see the cosmetic outcome, some, of course, information on pain scale and feedback from the patients. This was our initial thought, but we end up with a protocol that had to be adapted to our patients, because first of all, before surgery, you don't even know if the patient is going to have chemo or not. you know for sure that he's going to go through radiotherapy, but chemo is an unknown. And it turns out that the first patient got a positive lymph node, and she had to go to chemo, which delay everything. Another thing that we found useful was actually to do thermal imaging use, and I'll show you that. So here is our first patient. So this is a lady who is about 50 years old, and she has not very big breast, which is actually a challenge for the surgery. So Barbara did surgery on this patient on the right breast. The tumor was on the right breast a little bit above the aureolar area. And what you see here is the person before surgery. Then after surgery, you see that the breast is up. So actually, you may guess that there is a tiny opening that was done here on at the boundary of the aureola. So, I mean, this is a very good surgery, if I may say so, because it's really minimum invasive surgery in some sense. And then we can see that in this long-term follow-up of the patients for 34 weeks, the breast shape is going to change, and actually some very, very simple criteria is to look at the tip of the breast, and it's going to have motion up and down depending on what's going on with the biology. This is actually very interesting. And again, Barbara was very careful in choosing these patients because the tumor was rather centered, so it makes this first case easier to analyze. And I think that is quite interesting is to see that there is a lot of metabolic activity going on. So this is what we got thanks to thermal imaging. If we look at the temperature at the vertical of, I mean, in the area of the lumpectomy on the right breast compared to the left breast, we see clearly that the right breast is has a much higher temperature than the left breast, and for an extended period of time. And of course, the maximum temperature difference is right after surgery. So this is some kind of indirect measurement about what's going on in terms of inflammation and healing, which can be expressed in terms of metabolic activity and then heat radiated at the surface of the skin. I talk about this change in physiology, in anatomy, in the position of the right breast versus the left breast. So this is actually the curve, where you see that the right breast is going up after surgery, then going down, and then going up again. So there are clearly several periods in time in this healing process. And actually, the patients went through radiotherapy after weeks 20. Thanks to this surface imaging reconstruction, we can get volume. And we see that the right breast is getting bigger than the left breast right after surgery, and then it stabilizes again. So those are measures that we can actually interpret in our modeling and simulation, or that can be used in the modeling and simulation. And I will explain that a little bit further. So how do we do modeling? So we have to start step by step, and the first things, of course, is to start from the image. So this is actually the reconstruction that Remy did from the breast. The patient is in the prone position. We got the MRI, and we can reconstruct the surface. And also from the MRI, we can do tissue classification and show the difference between, let's say, fat tissue and glandular tissue. And this 3D reconstruction is just the first step. So obviously there is a difficulty already here, because we want to compute the position of the breast in the vertical position, or when the patient is seated. So somehow we have to invert the gravity and then change the direction of gravity. This is an inverse problem that is highly non-trivial, and we use an hyperelastic model for tissue elasticity, and we do have to take into account that the fact that the stiffness of glandular and fat are not the same, and of course the skin has another set of properties. So we have really a 3-layer models. Now, what we can do is that actually we can reconstruct the position of the breast in the seated position, and we get this red curve, while the blue curve is actually what we observe from the image. So we see some difference here, and this shows what happened in a clinical test. And fortunately, when the patient was on the MRI machine, her breast was next to the plate here and there. So basically, we made the problem too complicated, and that's why we are here. We have this discrepancy between the prediction and the reality, and we have actually to correct for this additional disturbance in the image acquisition that we didn't count on. Anyway, this is feasible. So it means that at least we can use tissue mechanics to reconstruct the breast shape. Now, with a little bit of validation and so on, we are in a position to go next with virtual lumpectomy. This is actually the goal that Barbara mentioned. So we do get the MRI image, we do get tissue classification, we have an hyperelastic model of tissue deformation, and now we can virtually do a lumpectomy here and see what is the effect on the breast shape. So this is this looks like classical mechanic, if I may say so, for tissue mechanic. A lot of people have been working on that, but unfortunately, it doesn't give the answer to our problems. And this is going to be much clearer here. Because what happens is that if I go back here, right after surgery, the empty space left by the lumpectomy is going to be filled up with seroma, and the breast is going to be very hard, and actually is going to go up, and this pocket is going to have high pressure of the liquid. So we cannot even validate this sample virtual lumpectomy, because now we have to build up pressure here, increase the stiffness of the tissue due to the surgery, and then we will observe that, of course, the tip of the breast is going up, like we got in this first curve. Then during that period, what happened is that the seroma is going to be more or less absorbed by the lymphatic network. And we have this really simplified three-step process for the healing that we can describe, with first inflammation, blood clot, providing homeostasis, recruiting of macrophage, cavity fill up with liquid and pressure buildup that I mentioned. But second, the tissue formation with cells recruiting at the boundary of the wound due to the loss of contact inhibition and production of collagen and so on. And eventually, in a longer period of time, tissue remodeling. And once again, it's not going to be as simple as predicted. And this is really the reality of the clinical conditions, because the patients, as I said, during this third period is going to go through radiotherapy. So while this is kind of reasonable to have with the model, the fact that the breasts go up again, it's the consequences of two things. Number one, you change the stiffness of the tissue, at least for an extended period of time because of the radiotherapy treatment. Second, you have a loss of mass and a change of stiffness of the tissue inside the lumpectomy. This is part of the healing process. So indeed, we can put that in our model and retrieve this motion up of the breast. But it's still very qualitative, not very quantitative. So that's where we stand with this business. So from the modeling and simulation point of view, we have many options to translate this repair into something that we can simulate. The first one is just to ignore the detailed biology and to have some kind of normal velocity law applied to the wall of the lumpectomy to simulate the wound healing. And the whole idea is to get the right equation for this kind of constitutive law of healing in order to get the right deformation, and of course calibrate that with our clinical test. This is kind of classic. It's a bit new for this kind of internal healing, because now we are talking about soft tissue, and obviously this process is very much depending on the strain energy, the location of the tissue. So, I mean, we have been working on that, and we have some interesting results. And we can put that into now our multiscale simulation, where we can apply tissue mechanics, get the stress computation into the tissue, and advance the healing process according to the stress, and actually according to the local curvature, which is another important aspect of this kind of model. Basically, because of the reaction diffusion of growth factor. So how do we do a validation with such a phenomenologic model that take into account some biology but not so much details? So first idea is to compare that to our clinical data set, and we have done some preliminary tests with our first patients. But another way of getting consistency between models is to compare this phenomenological model to actually a bottom-up approach, where we really try to mimic the biology of feeding with an adjunct-based model. And we learned some of that, and we were able to do some simulations. So if you remember, for example, the image of the second patients where the lumpectomy was not so successful, this is typically happening when the pocket is below the breast. This has a more dramatic effect than here. And we can follow up as I said, you can follow up the healing process and see this motion happen down of the tip of the breast, which is relatively coherent with what we observe, and develop a full adjunct-based model. So we all got excited about that, and we end up with a fairly sophisticated model, actually, that is going to have into that takes into account many players. We are talking about fibroblasts. Yeah, the sound is okay. I'm sorry. Yeah, we are talking about various types of cells: fibroblasts, myofibroblasts, extracellular matrix, and a bunch of molecules. So we have built this beautiful framework, and then I had a serious discussion with Barbara, and she said there is no way we can validate that in clinical conditions. So it's obviously a very interesting research aspect that we will have to push, but this is not our priority for now. We want to have this kind of medium complexity model that will be good enough to predict what's happening in terms of cosmetic outcome, but we can still calibrate. And especially when we go for this complex multiscale model, there is a big unknown. It's how do we deal with fat cells? This is actually a challenging question. So my conclusion is that we have a computational framework, and we have been even able to implement that in a distributed computing environment, which makes sense because cells are in large numbers, and tissue mechanics, it's a completely different framework. And where we are is precisely here. We are on a rough sea in order to use this kind of multiscale model for real patients. It's a very difficult task, and we certainly need to have more data acquisition, especially MRI to follow up the patients, which is not reimbursed by the health insurance. So we have to deal with these kind of things. We would rather use sophisticated 3D ultrasound, but again, this is not so easy. But we do make progress, and I think probably the best outcome is this dialogue between the surgeon and the computational scientist, who try to establish together a new discipline in order to go from observation to predictive models. And so we keep in always on our horizon the Fujiyama. That's where we want to go. So this ends this presentation. Maybe you want to ask a couple of questions, either to me or to Barbara, and then we move on to the second presentation. Yes?
Look, Mark, like you had some kind of a combination of agent-based and deterministic modeling in there. Is that
Let me, can you repeat, because I hear you with difficulties, please. Can you repeat your question? I think there is a technical problem. We don't get it.
Yeah, I think that might be Bill Litton. It seems like he's having some computer problems.
Okay.
Maybe I can ask a question.
Yes, please.
I was wondering, like, say, in your breast model, you know, breast is not a homogeneous material, right? So do you need to consider the those internal structures that has different material laws?
Yes, indeed. And we try to get something that, well, we find out this is important, but we need to also simplify our description. So we have 3 components. We have the envelope made of the skin in our finite element model, and we have also 2 types of tissue, fat and glandular.
Yeah, and if I could add to that, particularly when we think about the individual patient and precision medicine for a given patient. There's great heterogeneity from patient to patient. Some women have very, very fatty breasts. Other women have very, very dense breasts with stromal tissue. So we certainly expect that the modeling will be different in women with those different tissue components.
And so, if I may, what we try to do is to calibrate those mechanical parameters in order actually to fit the reality. So basically, when we compute the shape of the breast, we actually can compare with what we observe from the patients. That's a way to retrieve some of these parameters.
All right, thanks.
So we use typically surface response to do it, and some optimization on the surface response. It's fairly straightforward, except that Remy found it very difficult, and it was very successful. Yeah, other questions? I should say that I didn't give you all the technical details, but we have actually a bunch of models. No, it's not one, it's many. So we have like 2 or 3 level set technique and a couple of models that are agent-based like. And we have a whole spectrum because we start from the very basic stuff where we just take into account cell division, and then we add different type of cells, different type of growth factor, and so on and so on.
An important parameter for patients to know when they're making a decision between breast conserving therapy and mastectomy as to what the cosmetic result of this operation will be. So it's very important to be able to understand that outcome from the beginning as women are making these informed decisions. And sometimes we can say, oh, well, it's not going to look very good. You can either say, well, okay, I'd still like to do it anyway. We could do a secondary reconstructive procedure afterwards. It doesn't necessarily dictate one or the other. But it is a very important piece of, as you think about patient-driven decision-making, this is an important variable for which there's currently no predictive opportunity.
Okay. Other questions, please?
I think your last slide is very interesting, but it looks, as you said, probably over-ambitious, right? So are you really going to make a try on that?
We did. We start.
But
So we have
to validate it, right? Then
yeah, we validate step by step, and that's what we are doing. So we got our first patients, and we wanted to see how things will go. And actually, from the first patients, we already learned what are the components of the model that are important.
okay, great, thanks.
So we have we are planning to have 12 patients, if I remember well. It's in the RIB, and probably our most difficult problem is to decide how we spend wisely the money, so we get really what we need, but we don't overspend on this kind of project because, as you can guess, it's very ambitious. And also we want to make sure that we have something that can be used later on. So you are not going to ask for 5 MRI. Very simple. Okay. Should we move to the next presentation, please? Yes, Kim, are you ready?
I'm ready.
Okay. Well, thank you so much, Kim. So you are going to talk about this ex vivo model for lung cancer metastasis, and I would like to say the following. I mean, this is really a fantastic job. The first time I listened to the talk of Kim, I was really fascinated by the construction of his model, all the logical steps that he took in order to build that. So my wish is that the computational science community is going to pick up on this model and do a real good job to put together a computational model of metastasis. I think this is really the goal here. So Kim, please go ahead.
Okay, so the title of my talk is Ex Vivo Model for Lung Cancer Metastasis.
Let's together.
I'm going to talk about what we see in lung, how the lung cancer patients and what we see in them when we follow them along, and then talk about some of the biology or some of the hypotheses behind how metastasis work, and how I've incorporated taking the patient information and try to develop a novel in vitro ex vivo model to study this deadly disease. So I saw a 72-year-old gentleman with a 60 pack year smoking history who presented with a cough. He had a chest x-ray and then subsequently a CT scan that showed right here, which was approximately 1.2 centimeters, very small nodule. And then what we do now is that we do a PET CT scan, which allows us to get a sense of if it has gone anywhere else besides that location. Look for metastatic disease. The PET CT is a modality that has a high uptake in areas of cancer or inflammation, and as you can see, there's high uptake in that nodule. Patient underwent a needle biopsy, and he was diagnosed with adenocarcinoma of the lung, which is about 30% of the patients with lung cancer typically have, and he was clinically staged at stage 1A. He underwent a minimally invasive right upper lobe lobectomy with a mediastinal lymph node dissection, and pathology came back as stage 1A adenocarcinoma, meaning that it had not gone into the lymph nodes or anywhere else based on the surgical specimen. The lobe was removed. So if you look at the patients who had his pathologic stage, his 5-year survival should have been about 80%. So this is basically the group of patients where we can actually provide a cure. So 6 months later, he had a surveillance CT scan, which showed this. Just to orient everyone, we're looking at a CT scan of the chest, and anything kind of the black is that's a lung, normal lung, and anything white here is cancer. So in patients with lung cancer, this is what we typically see. We see lung cancer cells that form a nodule, which we saw in its initial scan. Usually the blood vessels bring nutrients to the lung, and the nodule, if you follow them, they'll just grow over time at the primary site. And eventually it will spread to the distant organs, usually lymph nodes first and then to the other parts of the body. And the patients usually die from metastatic disease, not necessarily from the primary tumor. But the question is, how do you model this? And why did my patient have a metastatic disease 6 months later, while other patients with similar presentation usually don't? Most patients are alive 5 years later. So the whole field of, and we think that metastasis is the most important part of tumor development, and unfortunately we don't have a very good model to study it. There are a lot of hypotheses behind this, and the current hypothesis is the concept of EMT and MET. So EMT is something called epithelial to mesenchymal transition, where the thought is that at the site of the primary lung cancer, the tumor cells break the cell-cell and cell matrix interaction and then enter the circulation as single cell. And then in the distant organ, that single cell enters the organ again and forms a tumor, and undergoing mesenchymal to epithelial transition. So if you kind of picture that, basically you have a normal epithelium, undergoes some genetic alteration that leads into a carcinoma that hasn't really broken the basement membrane, and then becomes invasive carcinoma where the EMT has occurred, where some of the cells break off and go into the blood vessel. And then at the distant, in the blood vessel, it will travel, and then in the distant site, it will come back and go back into the liver or come back to the other lobes of the lung and form this metastatic disease. And there's no model, in vitro or ex vivo model, that can isolate this. And the goal was to kind of try to mimic this process. So first thing that we want to do was create, we want to make sure that the model will form a nodule. But the nodule had to kind of grow over time. The nodule has to be something that can be perfused with nutrients and oxygen. The nodules has to have the ability to allow tumor cells go into vascular or lymphatic circulation, and then these tumors have to be able to embed in a distant site. So a little bit of tall order for an in vitro model. So the whole concept was to start off with a cell culture cells. I'm going to label that, I call that a 2D cells, and then we want to form it and grow it in a 4D structure, and I'll go into a little bit more later, and then isolate the circulating tumor cells and then isolate the metastatic lesion. And I think we've done this. First, I'm going to talk about the 2D versus 4D. So the basis of the model is taking this is a heart and lung of a rat, which we take out, and then we develop this decellularization process. So where you can see the trachea here, and then there's a heart, and then we cut the heart, and then we cannulate the pulmonary artery, or basically the vessel that perfuses the lung. So we cannulate that, and through it we put in SDS and Triton-X, which is basically a soap that gets rid of all the cells. And we do multiple washes, and you basically form these lungs. So initially, the normal lung looks like this, and over time, with this process, we get this at the end, which basically has no cells at all. But the key thing here is that it preserves that basement membrane and keeps the separation between the epithelial and vascular space. And then the next thing we did was we cellularized it with tumor cells. So we took the tumor cells that we grew in culture, and we cannulated the trachea, which populates the epithelial space. And we did this with the A549 cells, which is a typical human lung cancer cell line. So it goes into the epithelial space, and the media is able to perfuse the vascular space, and which is separated by this basement membrane. And then we put it into a bioreactor, which and made the media pump through this. So it goes through a pump and an oxygenator, and the media goes into the pulmonary artery, perfuses the lung with the tumor in the epithelial space, and comes out and circulates it back. So this kind of mimics the vasculature that we see in patients. So the things that we found were very interesting. First, that the tumor cells, once it goes into the matrix, it starts forming nodules. Initially, they're very, very small. About day 2, we can start seeing them. But over time, it grows, and it grows in a very predictable way. So the question is, well, you know, this nodule, does that have any bearing or any relationship with what's happening in a patient? Because you can grow a lot of different things, but if it has no relation to what's going on in a patient, then it might not be applicable. So to answer that question, the first thing we did was, well, this is the same cell, A549 cells, grown on a 2D, which is just a petri dish. It's basically a plastic. So if you put these cancer cells on plastic, give them media, it's just going to start growing and dividing, but in a very flat fashion. Now, there has been a lot of development in trying to use matrix. So adding a matrix here, which is just made out of collagen and different types of acellular products. And if you put the A549 cells in there, what it does is that it forms these spheres, has a cell-cell interaction, and it does have collagen connection, so cell matrix interaction. However, it does lack the vasculature. And now this is the H&E of our 4D model. And I call it a 4D because it has that addition of having circulation, allowing the fluid to go through. And what you can see is that you have this nice architecture that you kind of see on a regular. So we grew the same cells in a kind of different environment, the 2D versus 3D versus 4D. And what we did was did a gene expression array analysis. Between the 2D and 3D, there's about 250 genes that were different. But in our model, there was 2,954 gene probes different, and 2,174 genes that were uniquely different. And we took this and then applied it in the gene expression array database where they matched the gene expression of a cancer and with the patient's outcome. So there's a compendium of this, about 1,492 patients with cancer that was where the gene expression was detected. And when what we did was we said, well, does the expression profile predict a good survival or bad survival? And what we found was the prediction from the 2D versus 3D actually predicted a good survival, and our model predicted a poor survival. And our model is designed to form metastasis, so we kind of expect that it will predict poor survival, and this met our expectation. 3D model, I think, you know, it's good, but I think what it does is that it kind of pushes the cancer cells into less tumorigenic state, and that signature predicted good, picked out a good survival patient. So this was somewhat a surprise to us, but it met our hypothesis. I mean, it fit our theory that, you know, this model or this the tumor growth in the model has some relationship to what's going on with patients with lung cancer. The one of the things that our hypothesis as to why this is happening is the formation of more mesenchymal characteristics, that what I talked about earlier, the EMT features, and the being in that 4D model turns these cells into more mesenchymal, which is expressed by elevation of vimentin, elevation of NK-hedron, which are the markers for mesenchymal, and then decrease in the EK-hedron, which is the marker for epithelial. So we see that both in the RNA level as well as a protein level. So next question is a formation of circulating tumor cells. And one of the things that we can do in the model is that as the media goes through the lung, the media comes out of the lung and goes into the bottom of the bottle, and then that gets picked up and circulated back into the model. And when we take the media daily, we can see actually live tumor cells in the model, in the media. And for this analysis, what we did was we used two cell lines that has very different in vivo characteristics. So there's a 393P cells when you inject it in a mice, it does not form metastatic disease, while 344SQ cells does form metastatic disease. When we put these two cell lines in our model, they both form tumors. 344SQ cells form tumors faster, and then the size difference, there was no difference after day 14. And in terms of number of circulating tumor cells, 344SQ form more circulating tumor cells initially, and then no difference later on. However, the characteristics of the cells were very different. So if you just take 393P and 344SQ that were grown on a petri dish, the 344SQ are more mesenchymal. There's higher NK-hedron, high ZEV1, higher vimentin, and lower EK-hedron. But if you look at the 393P 2D versus circulating, all the circulating tumor cells have less mesenchymal, while circulating has more mesenchymal characteristics in a 2D. how did that translate in vivo? So we took the 100,000 live cells from 2D and circulating tumor cells and injected in mice to see are these circulating tumor cells from the model have any biological impact. And this is what we found. The 344SQ led to mortality on the mice faster compared to 393P. But if you look at the 393P 2D versus circulating, you can see that the circulating tumor cells did not kill the mice at all. And that's what we saw if you inject the 2D in a subcutaneous space, while 344SQ circulating does kill the mice. So this fit what you would expect the circulating tumor cells to do when you inject it in the tail vein. So finally, going from the circulating tumor cells to the metastatic lesion, what we did was we used a cell line called H1299, which is very aggressive. And we modified the model by, we tied off the S lung goes to, from the trachea goes to the left and right bronchus. We tied off the right main bronchus, which prevents primary tumor from seeding the right side. And all the tumor went into the left lung through the trachea. And only way for any tumor cells to go to the right through the pulmonary artery, and then tumor cell from the right lung from the circulating tumor cells. So we grew this for about 30 days. You can see increasing the circulating tumor cells in the media, and you also see increasing number of metastatic lesions. So the cool thing about this is that you can just take the, there's 3 lobes on the right, and we can take the lobe on different days. So upper lobe was taken day 14, and you can see these few cells here. Day 21, much more. Day 28, much more. So, and it was significant as the number of days went. So in conclusion, the ex vivo 4D model may mimic the biology of lung cancer growth and metastasis occurring in patients with lung cancer. And I think this model may provide better understanding of biology of tumor spread and potentially provide targets for novel treatment for lung cancer metastasis. And my thought was for the community is that, I mean, I think it's really hard to model this by just taking human data, but model like this, where you can get the genetic information and also have information about phenotypic behavior and how it moves through different phases. And I think there's more information to model this disease process much better. Thank you. Any questions?
Yes, I do have a question. This is Yang Lu from Lehigh University.
Okay.
Very nice talk. Actually, very interesting model. One question I have over here would be that, say you said it is a 4D model where you add in the flow, but actually I was wondering whether it is the blood flow that makes a difference, or it is actually the vascular structure that you have over there compared to regular 3D model, because you said those cells accumulate in the lobes, right? But actually those blood vessels have a lot of bifurcations. So I don't know whether those cells can accumulate over there that makes those like structured distribution rather than a general distribution. So I don't know.
So it's really interesting. If you put the tumor cells in the metastatic model just into the trachea, they kind of form clumps, and that's a distribution that's closest to the nearest trachea. In the if you look at the other side where the metastases form, they usually have a very even distribution in terms of close to where the vasculatures are, and vascular spread onto that lung is very evenly distributed. So, but I think you definitely need flow for this model to work, because if you have no flow, then obviously the cells can't get the nutrients, and cell can't leave the original primary tumor and go to the metastatic site.
What about, like, say, if you seed enough cells and then you stop the flow and let it grow and then provide like media once a while rather than continuously flush it? Is there any difference? So you just say you kick out the flow behavior.
Right. Without flow, I think the cells will die, because we're talking about 25 million cells. And obviously cells without being, and they're kind of be hanging in air in the model. And without media, basically all the media, without flow, all the media just drains, and all the cells won't have any nutrients. And without any nutrients or oxygenation, they'll just start undergoing apoptosis.
Okay. Have you tried to scan the exact location of those cells, say, for example, using some fluorescent levels where it tell you the, say, distribution or exact location of those cells?
In terms of getting a CT scan, you mean, or what do you?
Well, something like that, or using fluorescent like level.
Yeah, okay. Yeah. So the interesting thing is that I'm not sure if you're seeing the PDF. You can see the PDF. Okay. So you can actually see these nodules here. That's because the acellular lung is very translucent. So you can kind of follow them. You can take pictures, and you can, see how they're growing and how they were distributed. We typically get a very random distribution when we put the tumor cells directly into the trachea, but the more predictable distribution on the metastatic side.
Bill Lipton here. Can I be heard now?
Yes, I can hear you.
Okay. So I wondered if you had thoughts about where you might be able to take this in terms of a computer model, maybe something agent-based, where you have questions from your animal model that you think could be assisted by looking at this in a detailed quantitative way, a simulation of some sort.
So the interesting things that we've gathered so far are that this is just one cell line. This is 849 that you can see nice steady tumor size increase, and then also seeing the number of circulating tumor cells. But when we use H1299, it has a different pattern in terms of how the tumors grow, and then there's difference in terms of number of circulating tumor cells. There seems to be difference in terms of metastatic lesion formation. So the cool thing about the model is that the environment is very clean, in that it just basically matrix, and the input is going to be knowable, meaning that we should be able to genotype the different cell types that we're putting in. And if we can correlate the genotype and how that translates into the increase in tumor size, number of circulating cells, metastatic lesion, and then if we take all of that data and then say, well, that type of genotype relates to this kind of survival in a human lung cancer patient, then I think all of that will be of value to the people to just try to understand how all of this could be correlated.
Yeah, absolutely, of great value. That would be something of a statistical model. Another approach is the multi-scale modeling type approach, where one takes account of, for example, cell properties, and in this case, the property of the tumor. I could imagine taking account of friability, surface area of the tumor. I don't know whether these cells have any intrinsic motility. I assume they just go with the flow, but if they do, that would be a factor. And then make some predictions as to how, for example, simply a different tumor shape might have greater or lesser opportunity, and perhaps proximity to the blood vessels. I would imagine that would be a major factor.
Right, and then and also, we know that carcinoid tumors don't form metastatic lesions as much as adenocarcinoma. We know that small cell lung cancer do worse. And so just knowing what type of, I think first question is what type of cell and how is that related to all of this, but also, you're right, there's a lot of other physical properties that we can study.
Okay.
Does anyone have any other questions? These were two very wonderful talks. So as I understand it, Dr. Kim, you are not yet doing any computational modeling on your...
I'm not yet, but I've spent basically spent a lot of time developing this model, and we finally got it together. So once you get the model together, I think you can get enough information where you can potentially put that into computational. I don't think you can. I mean, you know, when first it was developed, we just didn't know enough about the in vitro ex vivo model to be able to, you know, model it. And then we want to. So we're not currently doing it at this moment.